Welcome everyone. Good afternoon. Our lecture for today is about vestibular migraine clinical management. It will be delivered by PT Nora Mallalah. She has 6 years work experience, 3 years in neurology and 3 years in vestibular rehab. She's also a Mulligan practitioner. She's a dry needle practitioner and of course a vestibular rehabilitation practitioner. Friends and colleagues, let us welcome our colleague Nora Mallalah.
Sorry. Can you like I need to share my screen right now, but I am not able to do that. Is that possible or no?
Yeah. I'll try. I'll do it.
Sorry.
Now it's on.
Okay. Yes. Hi, everybody. Good afternoon, and thank you for joining us. Like my colleague just said, my name is Nora Mallalah, and I'll be your presenter today. Hopefully, my voice is clear. If I'm not, just let me know. Okay, so today I'll be talking about the vestibular migraine and the clinical management for it. As you know, migraine is a very extremely prevalent disorder. Okay, it can affect all ages and all gender. So my presentation will be in how to manage this kind of patient that are coming to our department with misdiagnosed and poorly managed. Okay. So we'll start with the definition, and then we'll go through the etiology and theories, and then through the symptom and diagnostic, investigation, management, and case study and conclusion. Okay, so now everything's clear?
Nili's joining.
Yes.
Clear, Doctor.
Okay. We'll start. So what is migraine? Migraine is a type of headache. It may occur with any symptom like nausea, vomiting, and when the patient is actually sensitive to light and sound. So what's the difference between migraine and headache? Like a throbbing pain, while in headache, it will affect the whole head area. Okay? So there are many types of migraine. We're just going to be focusing on the migraine. All clear? Okay, let's continue. Now, what is vestibular migraine? So to make it more simple, the vestibular migraine is when a patient have migraine and start to develop a vertigo episode. For those people who does not know what is vertigo, it's when the patient feel like there's a spinning in the environment. Okay, which is different from dizziness. The dizziness is actually when a patient is feeling that his head is actually spinning, but the environment is a station. Please, can you turn off the mic? Okay. So vestibular migraine, it can occur in any age. Well, lucky us, female always get it more. So it's a ratio of 5 to 1. So the female will get it more than the male. So in every 5 patients, 1 male will only get it. And interesting, in children, actually, they start to develop this very early, from the age of 1 to 4. They will call it a benign paroxysmal vertigo of childhood. And later on, it can manifest to vestibular migraine. Now, let's talk about the theories and etiology. So we all know the old theory, which is the vascular theory. Anybody have an idea about that? Anyone?
Seems no one, Doctor.
Okay, so the vascular theory is when there was a vasoconstriction, and then there was vasodilation. This is like the old theory. I think everybody know about this. So this is now discarded. Nobody's using that theory. And there's a lot of new theories coming to light, like the brain is hyper-excitable brain. There's a dysfunction in neurotransmitter that would cause this vestibular migraine. And the most one they are using right now is the cortical spreading depression. Okay, we will not go through all of this. Anyway, now we'll talk about the symptom and diagnostic. So the International Headache Society actually classify each different migraine. So for that, they have a diagnostic criteria for it. When a patient comes to you, the patient should at least have 5 episodes of vertigo. And each episode should last at least from 5 minutes to 72 hours. And it should be exaggerated, and the patient intensity should at least, like with the increase with the head movement or head position, with all the movement will cause the vertigo. The patient should have a history of migraine, 1 or more migraine feature, like the patient should have a headache in one side, which is, like we said, is pulsating and increased by movement. Or the patient should have a photophobia and phonophobia. Photophobia is the fear of sound, and the fear of movement, and the phonophobia is the fear of sound. So they have sensitivity to light, to voice, and to images and light. Now we'll talk about the visual aura. Visual aura, the patient also like sensitive because it's sensitive to light. So when they are, let's just give you an example. When a patient is, let's say, is moving, he will feel like the whole area and the place is moving. Okay? And at last, the patient should not be diagnosed as vestibular patient or have been diagnosed as other migraine disorder. Okay, so when a patient comes to you, he will have 1 or more of these symptoms. We just said that the patient will be having a vertigo or dizziness. Like I said, the visual vertigo, when he's going to the grocery shop, he's not able to tolerate the grocery shop because he's not able to, let's say, look up and down. Okay, and also when he's going, like, let's say, he's going to, like we said, the shopping mall, the people moving around him will cause him to get dizzy. Okay, other things like nausea, motion sickness, imbalance, mild hearing loss, and anxiety disorder. You should know that all the patients who have migraine, whether it's migraine vestibular or other type of migraine, they will have anxiety disorder. Some of them, they will feel like they are dying, okay, like they're having a stroke, so they start to get panic attack. Some of them also actually have a fear of fall, like we always see with our patient, because they are getting vertigo and imbalance. And lastly, those patients also will fear they are going crazy, because a lot of people will not believe them when they are saying like, I feel like I'm in a boat, or like they are walking and suddenly like they miss a step, or like just pushing people or seeing things because of the visual aura they are keep seeing, that they will say like, I see things are flying, I'm seeing things that is not there. So they fear of going crazy. Now, we should know there is no specific diagnosed test for vestibular migraine. So how we actually know that patient have a vestibular migraine? We diagnose this by exclusion. So because like I said, the vestibular migraine shouldn't have or shouldn't be diagnosed as a vestibular issue or other migraine or any neurological disorder. So what we do tests to exclude the the neurological issue, the vestibular issue, and musculoskeletal issue. Okay, all clear?
Clear, Doctor.
Okay. So now we'll start with the management. The management, we have 4 types of management. Okay. The first one is we want to reduce the risk factor. Second, we will, of course, the medication we will not use, but I just want to give you an idea about that. There is prophylactic medical therapy, and we have the abortive medical therapy, and at last, this is our job, which is the vestibular rehabilitation. So we'll go through each one very fast. So let's start with reduction of risk factor. As you know, the migraine is triggered by a number of factors. The first one is stress. Second one is nicotine. Third one is estrogen. The fourth one is the diet. Okay, so for stress, we always ask the patient to fix their sleep schedule, start meditation, yoga, and exercising. And we want them to avoid hypoglycemia because the hypoglycemia also can cause stress and sometimes also cause dizziness for those patients. Nicotine, always stop the moment the patient comes to you and you know this patient have migraine, you always tell them to stop smoking because the nicotine can trigger migraine. And for the ladies, the estrogen. A lot of ladies with older age, they start to take estrogen supplement. Other than the vaginal cream, they will cause them to get dizzy. So they have to go for the gynecologist and tell him to change whatever supplement they're on for at least a trial for 3 months. Okay? For diet, anything with a tramine or food that increase the migraine should be avoided, this is something we actually can start working with the patient the moment he enters the clinic. And always ask the patient to keep a diary, which is to note the time and date for all the headache and the food they had ate 24 hours before the headache. So I'll just give you an example of the food that the patient should stop eating. So the moment the patient comes to me, I will just always tell him, avoid caffeine, which is taking chocolate, taking coffee, all type of tea, and stop eating food like the Chinese and Mexican and seafood because they have monosodium glutamate. Okay, this is like salt in this kind of type of food, and cheese, and the most important is cheese also. There's a smoked meat also can trigger like ham, turkey, hot dog. So anything that's packaged can also cause this dizziness. And nuts like almond, walnut, and cashew. Okay, so if you see in the other side, you will see the substitute, the thing they can use. And again, if the patient is drinking alcohol, so he also should stop that. Now, this is the medication that the patient will be coming to you. The prophylactic medical therapy, the doctor, the neurological, always use them with a patient who's having a severe type of migraine. Okay, and the abortive medical therapy is when a patient is having like a mild and acute type of migraine, is not getting a lot. So this, you will see this type of medication with those patients. Okay, the abortive mainly like taking the Panadol, the Brufen, and all of that. Okay, we will not go through that. We'll just continue. Now come to our management. So when the patient is coming to us, as you know, we're not treating the pathology. We're actually only treating the symptom that the patient is having. Because the patient will be feeling vertigo and he will feel dizziness, and the patient will be having balance issues, sometimes with the gait. So we are trying to work in that. So we have the Cochran-Coxie exercise. There are like a lot of exercise to just work with the patient. Okay, and we have the gait stabilization, and we have, like I said, balance and gait training. Now we'll go through a case. Okay, so everything will be more clear right now. So this patient was referred to us to the physical therapy. as a 27 years old female. She was misdiagnosed. Let's just say the patient was misdiagnosed as the right vestibular hypofunction. Okay, so when we saw the patient and her history, it didn't connect. So we asked the patient to go back to the ENT and do a couple of tests, which is the video video nystagmography. Okay, so they do this just to see if there's an issue with the vestibular and to rule out if the patient have a vestibular hypofunction. So this is the vestibular nystagmography. So we can see the eye movement. So we can see if the patient also have vertigo. And the result for this patient was normal. Also the patient went through audiometric test and they were also normal. No neurological abnormality. So MRI was not done. The lab test showed that the patient have a low iron, low vitamin D, low vitamin B, but she was already taking supplement. Also, the patient have a history of migraine for 6 years ago, and she was only taking the Brufen and Panadol. Also, the history of dizziness for the past 10 years. Okay, so we'll go through it now. All clear? Anybody have a question? Okay, so when you start asking the patient some question about her history, she replies, like I said, she's a 27 years old. She's a mother of 3 children. The patient was suffering from being unable to play with her children because moving with the children and playing around can cause her dizziness and unsteady. Also, because she worked as a lab technician, she was unable to do her job because it required that she sit for a long time looking through a microscope in a position that is very awkward and cause her dizziness. And she have to move, like lift her head and take sample from above and below her head, and this was causing her like to get dizzy and nausea. So when we ask about the chief complaint, it was, like I said, the dizziness and the vertigo, which have lasted with this patient for 3 months. And it took the dizziness and the vertigo, they just stayed for 45 minutes. And when the patient characterized her system, it was a constant lightheadedness and this equilibrium that increased, like I said, with the head movement and some certain visual environment. Like I said, the light was annoying for her, the noise when going to the shopping mall, when the people also passing by, this can cause also disturb to her and cause her to get dizzy. Going to the grocery store was for her, it was like a huge burden, and also playing with her children. So when we asked her, she did not complain of any weakness or loss of sensation or incoordination, but she suffered from mild tinnitus, which is the voice that can be heard in the ear, sometimes just or something like that, and abnormal vision. She getting a blurred vision while reading. When she went to the eye doctor, her vision was fine, there was nothing, but all of this because of the migraine. So like I said, the patient was suffering from dizziness for 10 years. She was only managed by beta-circ. But when she came to us, the beta-circ was not doing anything. That's why she came and she wanted another solution. Okay, now we wanted to ask more details about her headache. So when we asked her about her headache, what was the headache like? She said for the previous 6 years, it was a one-side unilateral throbbing headache. It was associated with nausea and lightheadedness and disequilibrium. But those times that she was suffering from those episodes, it was less severe than her symptom right now. Okay. Also, she had a history of motion sickness and family history of migraine. Of course, because the patient having this migraine, she's having an irregular sleeping pattern. And because she's a mother of 3, she's giving the excuse that she doesn't have time to exercise. Okay, so now what information was important in this scenario? That the first thing you have to have in mind, what is your first hypothesis for this patient diagnosis? And what sort of examination you will do to support this hypothesis? Okay, So we'll go through them. We'll take the first thing. Let's just analyze the patient history. And this is the patient symptom. Like I said, the first one, having a headache, the nausea, the vertigo and the dizziness, the visual vertigo that's happening when she's in the mall or playing with her children, the motion sickness, which will give me a vertigo and dizziness, having a mild tinnitus, which mainly we do not do anything about it, we'll just keep it in our mind. The patient will have this disequilibrium and balance issue, and lightheadedness. Now we'll take one at a time and see how we are dealing with those symptoms. First, we're gonna start with the headache and what as a physiotherapy we can do with this patient. Okay. So the first thing, the way I managed this patient, the first thing I saw her dietary. Okay, we had to try to fix her dietary. I asked the patient when she's coming to work, she have to go park somewhere far or come early and try to walk at least for 15 to 30 minutes a day, whether it's in the morning or the afternoon, and she needs to fix her sleeping pattern also. And the patient needs to also keep a food diary to know exactly when the patient is getting those headaches. So this is what the patient did. So she had it for every week, but I just give you one example. I'm sorry, it's in Arabic. I didn't have time to change the word. So in Sunday, she was taking normal food. She added the shrimp, but she did not suffer from anything in the day after. In Monday, the most important thing, the thing I just circle around, which the patient had Turkish coffee and she took noodles. Because two items here can cause her migraine. On Tuesday, the patient suffered from headache and dizziness. So on Tuesday and Monday, she took normal food. So on Wednesday, she took shrimp and she ate chocolate. So on Thursday, she suffered from headache and dizziness. And after that, she became a very good patient. You should see the other one. So she stopped and started to avoid those food. Now she believed that this kind of food will cause me dizziness and headache, so I should cut those food. So once she cut the food, the patient was getting less headache. So this is the result. At that time, the patient report less to non-episode of headache for the past 2 months that the patient was being treated in the clinic. Also, the intake of the Brufen and the Panadol have been reduced to 1 pill if needed. Okay, now we'll take the other type of symptoms. We have the vertigo and dizziness, the motion sickness, and the visual vertigo. All these three, we can treat it in the same type of treatment. Like I said, since there is no specific diagnosis for testing for the vestibular migraine, we test by exclusion, or we diagnose by exclusion. Okay, so when the patient first come to us, we actually hand them 2 types of questionnaire. One, to report their dizziness, and another one to report their balance. We'll talk about the balance later. So let's just take the dizziness. This questionnaire is called the Dizziness Handicap Inventory. Okay. So this is the questionnaire. It's about 25 questions. They have the physical aspect, the functional aspect, and the emotional aspect. The higher the grade, the patient is suffering from a dizziness issue. The lower, the better. Okay? Because the yes always will give you 4 points, the sometime will give you 2 points, and no will give you 0 points. Okay? So, and we also did for this patient Dix-Hellbike just to exclude that the patient doesn't have a benign paroxysmal position of vertigo, which is a vestibular issue. We do oculomotor tests to check if the patient have central disease. So we just want to exclude all of this issue. Because as you know, some patients with migraine actually will suffer from vestibular issue. So we just want to know, is it a mixed symptoms or it's just a pure vestibular migraine? So this is the patient, the one she did, it was in Arabic. Okay, like I said, this is the Dix-Hellbike. And the patient reported said she had negative in all. This is the management. We did the oculomotor test. We do the skew deviation, thrust test, a Sackett, the vestibular ocular reflex cancellation, ocular range of motion, and we're doing the smooth pursuit. So all these tests are used to, like I said, to rule out central disease. And this is the test result. The DHI score for this patient was 15. The Dix-Hellbike was negative. The oculomotor test shows normal result. So this patient suffered from subjective dizziness. So we cannot actually like test it or see it, but this patient does have actually dizziness, okay? So this is an example of the treatment that was given. We have the gaze stabilization exercise. There are too many, I'll just give you an example. And we have the Cottering-Coxey exercise. They all work to reduce this kind of dizziness and vertigo and improve the visual vertigo for this patient. So this is a couple of research, just the conclusion I put. This review suggests that the exercise-based vestibular rehabilitation will show benefit for a patient with a chronic dizziness. It will improve their vertigo symptom and also reduce their fall risk and increase their balance and decrease their problem with the emotional. Okay, and the other one also, like the vestibular rehabilitation, improve the quality of life. Okay, all of this happened in 2 months when I was treating the patient. Now, like I said, the patient is able to go to the grocery, shopping, playing with her children without suffering from dizziness. At the end, the DHI score for this patient was 4. She still has some, like, let's say, fear of fall. Still, we cannot that much manage those kind of things. Since before she had the fear of high places, so that's why she scored 2 and 2 on those. And it just was like sometimes she's having that. And after 6 months of follow-up on the patient was still in control. There was no reoccurrence of migraine episode. So now we will talk about the patient's symptoms. Okay, about which is the disequilibrium and the balance and the gait unsteadiness. Okay, so like I said before, the patient was also given another questionnaire, which is for the balance. This questionnaire is called the Activity Specific Balance Confidence. We call it for short the ABC. Okay, and we do like a Romberg test and the gait analyze for the patient. This is the ABC. We are seeing the patient confidence in doing her everyday activity. So from 0 to 100, how much you are confident in one of those things. It's about 16 questions. We calculate it together and divide it by 16. Like I said, from 80 and above, the patient have like a high function level. From 50 to 80, the patient have a moderate functional. And from 15 and lower, the patient is unable to do it and low functional level. All clear? So this is the patient questionnaire. She scored about 64.3, which is moderate function. She still has some balance issue in some of the thing. So this is the Romberg test before the treatment. We did everything like leg together, semi-tendon, one leg raise, on the floor, on the foam. You can see the patient was not able to score well. So this is the result. The patient scored, like I said, 64.3%. The patient balance result shows she have instability. When we did the gaze analyze, the moment the patient comes to you, especially if they have dizziness or vertigo, you will see them with a high guard gait where there's no to little movement in the neck. Okay, because any movement in the neck will cause them to get dizzy. So that's why first we have to make the patient be more confident on themselves, and when we're treating their vertigo and everything will become better. Okay, so as you know, this is some of the example we have been using. Okay, so like I said, this is for the balance. Of course, you all know the balance exercise. This is something we are using for the gait. We ask the patient to go forward, backward, walking on the treadmill. By the way, the treadmill for this patient is a headache because those patients already get vertigo and dizziness. So walking on the treadmill, it's the last step we are using for this patient. Okay, so after the treatment, the patient activities or the ABC score was 97.8%. Patient was having a normal gait. This is the Romberg test. After treatment, the patient scored high in everything. Everything was 10 seconds, so it was good. And this is within the first month of the treatment, the patient reported that her balance improved and her gait was more steady. Okay, so I put a couple of research just to prove what we are working through. This is a systemic review to show the effective of vestibular rehabilitation in managing individuals who have vertigo with migraine headache. So this included 5 studies. The result, it wasn't that really favorable because the vestibular rehabilitation was generally more effective for individuals with non-migraine vestibular disorder than those individuals with vestibular migraine. However, in all the 5 studies, every group of participants have benefited to some degree from the customized vestibular rehabilitation program. The conclusion, although it's difficult to draw any definite conclusion from this systemic review, vestibular rehabilitation should be seriously considered when treating individuals who experience vertigo associated with migraine headache. Because you cannot actually give all the patients the same kind of exercise. So in those studies, when you see them, you'll see each patient was giving a customized vestibular rehabilitation. And that's why they were not able to get a definite conclusion. The second study was for Susan L. Whitney, she's one of the pioneers for vestibular rehabilitation. She did this study to assess the purpose to see the efficiency of physical therapy for a patient with migraine. Okay, and it was about 39 patients. She was using the DHI, the ABC, and the DGI. And they saw there was a significant difference when using, they were seeing before and after therapy. Also, the conclusion was the same. The patient was actually getting more benefit from this. But the weakness of the study, because they did not see if the patient can be excluded from medication or other dietary issue. So that's why those kind of study a little bit were weak. Okay, so conclusion. Further study need to show the importance of vestibular rehabilitation to treat vestibular migraine. And any early reference will always minimize the time for recovery. This is my email if you guys need to ask question or something, because I don't know if we have time for that. And this is the reference. So thank you so much. Hopefully you all benefit from this. Anybody have a question, please just let me know.
I have a question.
Yes, sure.
The exercises that you did, the one in the chair, Cowthorn or something like that. How long do you do it? Like for repetitions, and how many days or weeks do you usually do it? I know that one of the cases you showed where it was done like she improved in 2 months, but as per repetition and how long before they improve?
Okay, so for how many times I'm seeing the patient? I've been seeing the patient for twice a week. Okay, that's the first. The session is taking at least 1 hour.
Oh.
The repetition, it's depends on that time. Like whenever the patient is able to do this exercise, I'm doing it with her. Like, because once the patient is getting vertigo and dizzy, I'm stopping the session.
Okay.
She's like increasing the symptoms. Sometimes I'm stopping that. I mean, not the session, the exercise itself. So sometimes I'm doing it for 5, sometimes I'm doing it for 10, as much as the patient can tolerate. As you know, one of the things, let me show you again, some of the exercise. Actually, I have, yeah, this one. Okay, see this exercise in the middle, I was giving to this patient. She was unable to remove, she was able only to remove 2 kind of coins at that time. And that's it. So I have to repeat it in every session until she was fully able to take all the coins out of the floor. And by the way, this one, I have to repeat it sometimes 4 to 5 times a session. So with them, with the patient with the vestibular migraine, you have to be slow and careful because you don't want to go too much and you actually go back 2 steps. So it have to be customized to the patient, like tolerance at least. You will see when the patient is getting tired and like getting dizzy, you will see in their eyes, they cannot focus. So at that time, you have to know that you have to stop this exercise and you have to go to the next one. Okay, so it's not like about taking just one exercise and doing 1, 2, 3. No, you have to customize it as much as you can. Like for the gaze stability, the thing we're doing with the eyes, let me show you. The card exercise, this one. Okay, this type of exercise actually really benefits with the patient. And you will able to do it as many repetition because this type of exercise, you're doing it only for 30 seconds. You ask the patient to keep turning. This one will actually fix their dizziness. So this one you can play around. The cardio exercise, I always give them as a home program because the patient will take maybe 4 minutes a day because there are many type of exercise. So the patient can do it at home, do it at work. As much as they can, they will do it. Other exercise, sometimes I be more like, let's just say I will do it in the clinic better. Because like I said, I'm seeing the patient for 2 months, so I can play around. So I don't want to give the patient too many exercise, but because they already have other responsibility at home, so some of them, they will not, let's just be real, they will not do the exercise at home. The only thing I'm giving them mainly, which is the stability, gaze stabilization. Other thing I'm doing in the, let's say just in the clinic. If you want, I will show you another video for vestibular rehabilitation. Let me just open this, sorry. I have other one. Vestibular. Yeah, this is the exercise. Okay, so this is the eye movement. I'll just show you very fast. This is the visual fixation and moving target, all of this exercise I'm giving to those patients. Sometime in the clinic, sometime at home. But trust me, each exercise, it's really difficult to achieve at the first 3 sessions. The patient will not be able to tolerate it for 5 seconds. This is type also exercise of Catherine Coxey.
Nora, we cannot see this video. I think it was not shared.
Sorry, again? I did not hear your question, sorry.
The videos, we couldn't see the videos now that you are showing. I think because I think it's not in the slide, right?
Yeah, they're not in the slide.
So
No.
maybe it was not shared, so we couldn't see from over here.
It's not shared right now?
Yeah, I'm not showing now. Only those in the slides.
Oh, okay, you're posting this, sorry. Can you open the share again?
Okay.
Resume share.
It's open now. It's open. Yeah, now. Wait. Now it's open. Now it's open.
Are you seeing the video or no?
No, still no. Maybe it's a different. Maybe it's a different way of sharing it.
Sorry. Oh, okay. Some people are. Okay. Let me try again. Let me share again. Okay. Okay. Now you see those?
I see therapeutic exercises.
Yes, yeah. This is the exercise I'm giving mainly for all the patients that are coming. This is the most important thing. This is the basic one. This is the eye movement, the head movement. This is the exercise I'm telling you for fixation, gaze fixation. This is what I'm actually giving the patient as a home program because each exercise, they have to do it only for 30 seconds. If they can go for 2 minutes, that's a good thing. But again, 30 seconds for vestibular migraine is enough because also like this for this patient, for the first session, she was only able to tolerate it for 2 seconds. And then she's getting dizzy. You can see the eyes is like she cannot able to focus with. So this is also another exercise. Catherine, like I said, you can see this all exercise to do like morely as a functional. This is, again, this is normal, the balance. You all know about the balance, so we'll just go through all of them. Okay, so there are many actually exercise we are using with the patient. So let's just stop sharing right now. Okay, so, okay, did that answer your question first?
Yes, yes, it does. Thank you, thank you. There's one more question. I don't know. I don't know if you can see it in the chat.
Yeah,
Uh,
Rami, to everybody. Hi, I used to get headache every 3 months. It worsened after some time. It's led to increase my hypertension. Started to use ketamine and paracentral. Okay, but when I do exercise, it will control. Otherwise, it will exaggerate. So, is there any precaution in the future of my life? Okay. So again, the headache. Rami, are you still there? Okay, can you open the mic if you're there? But just because I need to ask you some question. Okay. Hi.
Hi.
Rami is okay. Rami. Okay. So this headache that you're getting.
Yes.
Hello. Okay. Is it like, let's say, like I said in the slide, is it like in one side or you're getting it all over?
Only from frontal, off of the head, it'll be severe headache, and it leads to me. I couldn't overnight. 1 o'clock, 2 o'clock. It reached my peak level. Then I started checking my blood pressure. It was 170 by 110.
Okay.
So then I called doctor, and they told me, they gave me some emergency medicine, Capoten.
Mhm.
So I used to take that one. Actually, in Corona time, I used to do exercise, but I was controlled. Recently, 1 month, I didn't do any exercise for myself. So this makes me more worse than.
Okay. Are you getting dizzy with those kind of symptoms or just headache?
Dizzy. The peak time is dizzy.
Okay. I think you're more like a normal headache than actually, because like I said, the headache, you will get it in all of their head. The migraine, like I said, is different because it's just one side. Sometimes you just feel it like in one eye. Could be because of your hypertension, like you said, because like I said, it's already high enough. So taking medication is good. Like I said, you need to exercise. You can do the risk management for this. And if it's food, you need to fix that type of food. So if you're taking a lot of caffeine, reduce
But
it.
when I saw you diet, I'm eating all this side only, not this side.
So this side, you mean as in a good thing, or you're using the bad thing?
Bad thing, of course, bad thing. Chocolate,
all of us in
everything.
the bad thing. Yeah, so that's why you need to fix your diet. Actually, if you just stop the three main things, the coffee, the tea, and the chocolate, I think your diet will be better. The salt, I think we need to reduce that amount with the food that we're taking, but otherwise, just fix that and everything will be better. Because I think right now, because I suffer from migraine. Okay, so once I stop taking all of this, I'm not getting any more episode, even without doing actually exercise. It's fine. So just
good.
right now, yeah, we need to reduce that kind of diet because right now, like I said, mine is not that severe. It's just mild things. I'm not getting that busy. It's just the headache sometimes that happen. So that's why.
Do you remember I attended your class in the Faronia? Because of that, my headache, I came. I choose the topic. That's the reason. Okay,
so now
thank you so much.
You know the exercise and you know everything.
Yes, that's what. Okay, thank you so much.
You're welcome. Any other question? Thank you. So anybody have another question? Or you're all good?
I think they're good. Okay. Once again, on behalf of the scientific committee of the Fidencina Hospital, we'd like to give our appreciation of the time you gave to us. Thank you for your very interesting lecture today, and we hope to be able to invite you soon in our future projects. Inshallah.
Thank you. Inshallah. I'll be there whenever you want. Thank you so much for having me today anyway. Okay.
Thank you everyone who came.